So without using any more words on that, I would like to introduce my first speaker, or our first speaker of today is Tony Elmos Andersen. Tony, he is a professor of pain psychology at the University of Southern Denmark. His primary research focus is on the prevention and treatment of post-traumatic pain, with special focus on whiplash-related disorders. In his work, he tries to map psychological risk factors for whiplash-associated pain, and he has contributed to the development of new treatments for both the prevention and treatment of the condition. So before I give the word over to Tony, I would like to tell you that there will be time and space for a few questions immediately after his talk. But before both presenters have concluded their presentations, we will sort of have a panel discussion at the very end where we will try to sort of, with the help from the experts we have invited here today, to see what are the trends, where are we going in the future, etc. And so feel free to save all your questions until the end. So without further ado, I want to invite Tony to come here.
Okay, thank you, Toraldur, for that presentation. It's definitely nice to be among so many skilled physiotherapists today. I guess I'm one of the few psychologists. So I have a background as a licensed psychologist where I have worked for more than 20 years now with chronic pain rehabilitation. And lately, I've done a lot of research into how to prevent and treat chronic whiplash-associated disorder. And I'll show you today as a finish of my talk. Is it okay?
Yeah, just sounds coming through.
I'll show you some examples of two trials that we have recently conducted. The one we have just finished. The trials are quite interesting because we have tried to implement some of these psychological approaches into pain management. And the first trial is a very traditional RCT trial where we have invented almost, I'll say, an intervention that we call value-based CBT. And I wondered whether I should call it CBT for dummies when we did this trial, because we have tried to make things very, very simple of how to apply these psychological skills for non-psychological professions. But we ended up calling it value-based CBT, as you'll see why in a few minutes. And then the other trial that I will show you is quite interesting because it's a single case experimental design, which I'll go more into details with, that allows us to open up a little bit this black box of what's going on during treatment and what the effects are. And what's interesting about this work as well is that we developed or adapted this program very closely in collaboration with physios. And then they delivered most of the treatment, except from the first 3 sessions where a psychologist helped the patients. But I'll come back to that. But I'll start another place. Maybe I can I? So I'll start to ask you, what should we actually treat when we try to prevent and treat pain? I'll just, a brief open question for you guys. Anyone there to answer, what should we treat to treat pain? Any suggestions? There's no wrong answers, or there are only wrong answers. I don't know. Anyone? Not Morten.
I think we need an answer. We wouldn't be faced with challenge.
True. So I'll talk about what I think we should treat and what some of the experts think we should treat. And to do that, to answer that, I'll just ponder a little bit on what pain is. And I'll give you some examples from placebo research, because that's actually a quite nice model that shows us how we can modulate some of these pain mechanisms from a psychological perspective. And then I'll talk a little bit about what skills are needed and how we can apply them. So what should we treat? Well, I'll postulate that to treat pain, we should not treat pain. And that's somewhat of a paradox, right? But what I'll postulate is that sometimes when we try to treat pain, when our patients have suffered from pain so long, then we just reinforce negative pain behavior and this being stuck in the pain problem. So instead of treating pain, if we could treat pain, then obviously we should do that. But sometimes we don't have an effective treatment directly for pain. So I will quote William Miller, the author from Motivational Interviewing. He says it quite nicely in a textbook on medical psychology that we just finished. He said that whether or not a disease was caused by lifestyle, its cause, management, and outcome are often intertwined with behavioral choices. So behavior change is therefore fundamental in healthcare, yet it often receives relatively little time and attention in medical training. Doctors don't do behavior, a consultant physician once told me. I'm sure that you are not that radical in your opinion on that, but I guess that it's not wrong when I say that it can be difficult to treat pain and it can be difficult to treat behavior and to know how to treat behavior. So it gets too little attention. So I'll talk a lot about how we can treat behavior and where to start today. But before I'll do that, I'll show you a little example from the placebo research, because placebo is a nice model to understand why these psychological factors, they have a profound effect on something very objective, how a painkiller works. And it really shows us how expectations and how prior learning history actually creates effects. And prior learning history and cognitions and expectations, we can modulate those. I won't spend too much time on placebo, but I'll show you a simple example anyway. So this is a very traditional placebo study where we have different painkillers. And what this study shows that many of you probably know, if we give a painkiller in an open fashion, where we give the pill or the injection and saying this is a painkiller, compared to if we give it in a closed fashion, a hidden fashion, like in a morphine drop, then the effect is twice as big just because we expect that we get the painkiller. So these effects are quite remarkable if we can double the effect of a treatment just by creating expectations, positive expectations in our patients. The other way around, we also know that if you are on an effective treatment, for instance, after surgery, and you tell the patient here, now I discontinued the treatment, then very quickly in the hours after we see the pain levels, they rise to excruciating levels. However, what's quite remarkable is that if we don't tell that we discontinued the treatment, we just keep the patient on the morphine drop and we discontinue the treatment, then they are almost equally covered in pain. So what does that tell us? Well, this is really hard evidence that the so-called active ingredients in the tablets or in the syringe or whatever medicament you're giving, that's not the only effective treatment. And in many ways, I guess it's the same in chiropractics and in physiotherapy. We have for many years talked about that we are in a crisis because it's not the exact exercises, it's not the manual therapy. We can't tell what works and why it works. But I don't think that's a problem because we have a lot of other factors that we can modulate. And in psychology, we have known that since the 1936 that these common factors and contextual factors are important. But we can't do contextual factors and expectancy effects around nothing. So of course you should do your good exercises and manual treatment, but we can enhance the context around the treatment. And this is what I'm going to tell you about here today, how to do that. So pain is quite complex. I discussed it with Morten and other good colleagues here just before the seminar, because the brain, we know that it doesn't passively, receive pain signals from the periphery. And to put it even more provocative, these placebo researchers, Ongara and Ted Kapchuk, they have stated like this, that we don't necessarily feel pain because we sense it directly from the peripheral body. We feel pain because we predict that we're in pain. And that's quite a provocative statement. I guess it's not, or of course, it's not always true that we only feel pain because we predict pain. But pain has a lot to do with classical conditioning and operant conditioning. If we have prior experience with something giving us pain, then the brain is really ready to receive these signals from the body. Even neutral signals can be interpreted as pain. And as I will finish with, even when we have our life roles and life values are threatened, we get more sensitized to pain. I'll show that. So this is something that I often talk with the patients about in our trials, that this threat value of pain that can actually create pain. And a nice example is always to show some brain scans and show patients how this works. And we actually sometimes use this example in the clinic as well to tell patients about that pain is more like a memory. If we think we will be in pain, then the brain is ready to receive pain. This is a study where in a scanner, in an MR scanner, that these researchers, they have inflicted pain, and then we can see the pain matrix, pain areas or areas in the brain associated with pain, they lightens up. And then these researchers, before they inflict pain, now they flicker with a red light. Second before the patient will receive pain, or the participant will receive pain. And what we see then is that just by flickering with this red light, when they have learned that in a few seconds they will receive pain, then we see just the expectancy of receiving pain that activates overlapping brain areas. Not so much the somatosensory areas, but a lot of other areas that makes the brain ready to receive bodily signals. So a lot of patients understand this, that the brain gets ready to receive pain. And if you have had pain for 10, 20 years, then your brain is really ready to receive all kinds of signals from the body. So a lot of this treatment where we apply psychological approaches is really about creating new expectancies. It's really about exposure, of course, contextual cognitive functional therapy and stuff like that. They also work in this area. They create new bodily experiences. But there are other ways around this as well, as I'll tell you about. So finally, I'll just show you this one. This is a model of how placebo actually works, because we have the external context, the internal context, and then we have the therapeutic relationship. This is actually some of the very nice mechanisms that we know a lot about that creates these placebo effects or expectancy effects, if you will. And all these factors are actually something that we can modulate and work with from a psychological perspective. We have the verbal suggestions, the words that we use in our treatments. If we make it obvious that now we are doing a treatment that's going to help you, just by saying that can actually enhance the effect. Or this is a very good exercise. Many patients like it and have good experience with it. That can actually increase the intervention as well, or the effect of it. And then we have all the treatment cues. That's more the negative part of it, because we know the more invasive a treatment is, the better it actually works. So that's difficult to modulate, I guess. But then we have the internal context, all these expectancies. And this is where the psychology part kicks in, because we need to assess all these expectancies. We need to modulate them to create good expectations for the treatment and to help patients feel in good hands. So we can strengthen the therapeutic relationship. We can frame the treatment and have it to make sense for the patients. And to frame the treatment is actually to tap into how the patients perceive their pain problem, and frame our explanations on top of how they perceive the pain problem, and not just start psychoeducating and knowing better. And then we can reduce negative feelings and anxiety, and we can use the right words and suggestions. So all that is the psychological mechanisms that I'll talk about. we have this therapeutic relationship right here that is made up of a lot of mechanisms: empathy, validation of the patient, and the therapeutic alliance and working on common goals. And there are actually techniques to develop that. Then we have the exposure part. There's what you know a lot about: fear of movement. We know that we can do exposure exercises, but there's also something that you may know less about. If we can help patients to identify their life values and help them to proceed going in the direction so they fulfill their life roles and values, and to set value-based goals and translate those into value-based activities, then we actually see that they get less sensitive to pain and they experience less symptoms. And this is a very psychological process to help the patients discover what's most important to them. And often they have forgotten that, having had pain for many, many, many years. They put their life on pause until pain disappears. But when pain doesn't disappear, then years down the road, their quality of life has decreased substantially, and they have given up a lot of important activities. So this is really as simple as that, and to help people focus on these life values and encourage them to fulfill them. And this may require working with a lot of behavioral change techniques, because not every patient is equally psychological flexible, or they don't accept their pain problem. They want quick fixes. And it also has to do with motivation to do the right things to change the pain problem. So I guess these are the techniques that you have to apply into your clinic when you're working from a psychological perspective with incorporating these psychological techniques. We've known that for years, as I started telling you, within psychotherapy research. This is a meta-analysis done by Bruce Wampold years ago, where you can see the effect size is here, the up here, and the width of the bar is how many studies is done. And if you look at the specific ingredients in psychotherapy, the effect of those, they have a very, very little role in the outcomes. But what we can call these contextual or common factors, like empathy, the therapeutic alliance, and working on common goals, that's actually what drives the effect. And we have known that in psychotherapy research for years. So we need to adopt this, take on pain rehabilitation as well, I guess. So what are the barriers to implement some of these psychological techniques or this psychologically informed care into treatment? If I ask you, if this is difficult to do, if I ask you, and what are the barriers? What do you experience at the barriers? Just give me a few examples. Why is this difficult as a physiotherapist? Knowledge, you need knowledge. Yeah, that's a good one. You need time. That may be another one. What else? Is it easy to do counseling? No.
Training.
You need training, yeah, of course, because you haven't had it like part of your curriculum in school, right? Exactly. You may feel that you are overstepping boundaries. This is not within my area. And it can maybe be a little dangerous to ask into feelings and how they feel if you don't know how to cope with it, if they get sad, or if they are very very distressed about the pain problem. Yeah, that's good reasons. Actually, a recent review in pain, they have assessed this, what are the barriers and enablers to adopting a biopsychosocial model in musculoskeletal pain approaches. And what they come up with is a lot of what you have already said here, that you're lacking what we can call these soft skills, these communication skills, what we can call this counseling skills to facilitate patient disclosure, and also this about dealing with sensitive topics. You're not used to that. And also it can be challenging to work with resistance, because if you try to have patients to see the pain problem in another perspective, and you need to have patients to change behavior, then you are faced with resistance and how to do that. Then it's often easier to fall back on what you know, your exercises and your manual treatment and etc. So also, as you mentioned, you can be reluctant to ask about these social factors, right? And often we also met with patients that wants to be fixed. They want a simple explanation. Where is my pain? And then fixes. I need some reassurance that you can fix it. So all this is, pulling in the other direction. Another study that's a mixed method study is also quite interesting. This study had the aim to identify promising practices to foster better clinical encounters between the physician and the patient. This is not just pain patients. But what they did in this study was that they did a systematic review, and then they did observations in medical clinics, observational studies about encounters between patients and physicians. And then they did qualitative interviews with both physicians, patients, and other non-medical professions, what they valued as most important to enhance these medical encounters. And then finally did a Delphi process where they asked researchers, clinicians, patients, and caregivers, and also healthcare system leaders, what's most important to enhance these medical encounters. And all actually agreed this is very simple soft skills. You need to prepare, of course, with intention. Then you need to listen to your patients. And then you need to agree on what matters most. You need to connect with the patient's stories. You need to really understand how the pain problem affects their life roles, not just how the symptoms are. And then you need to explore these emotional cues that the patients are giving you. So if they use emotionally laden words, then you need to follow up on these words. If they express that this is very frustrating, then you can just mirror back, oh, you said frustrating. So explore emotional cues is very important. And it doesn't take much time. It's about connecting to the patients. Really put yourself in their shoes and understand how is this pain problem affecting you in your life, and what life roles and what values are threatened. And this is really as simple as this. But of course, we need some structured ways of doing this. And I'll show you how this can be done in a structured way. I think this is very catchy. This is a Norwegian initiative back from 2014. It started the What's Matter Day. Do you know about that? No? But yeah, you know about it. Yeah. But they have a very nice homepage where you can get a lot of materials of how to engage with patients and how to communicate in meaningful conversations with patients. I think you should check that out. But I just took it with here because I think it's very catchy. What they say is that you need not only to care about what's the matter with the patient, you need to care about what matters to the patient. I think this is very clever way of putting it and remembering it. Also, a recent review have just been published in Scandinavian Journal of Pain by the grand old men that are authors to the fear avoidance model, Stephen Linton and Blaine, and also, Peter O'Sullivan with the functional physiotherapy. Well, they put up in this nice paper, if you haven't read it, then please do it. What they have claim or what they put up is that it's really important to act in a clear and empathic way in your communication with the patient. You really need to understand their problem, to connect with their problem, not just their symptoms. And of course, the patients, they want the most effective treatment. That's the patient needs. But what's interesting is that your main goal of treatment should be to hinder that pain interferes with their lives. So you need to treat disability and not necessarily symptoms or functional limitations. You need to treat their lives. You need to help them address valued activities. And then it, of course, requires some competencies among the clinicians. There are these soft skills. You need to be able to screen and identify the problem. And that's not just the biomedical problem, that's a problem in the patient's lives. And then you need to be able to reconceptualize the problem, to identify these valued activities and set goals, to use this very personal information. Sure. So how to do that? As I start telling you that we have made an intervention that we call value-based cognitive behavior therapy, where we have tried to actually focus very strongly on these valued activities and reconceptualizing the pain problem. So what we do in these programs is that we're starting with asking the patients to, in different domains of their lives, how they are compromised. And then we ask them what are the most important areas in their life. And then we ask them, what would you wish that were better? And then we translate those into goals, and we talk about them, what values are behind these disabilities that they experience. And this is really inspired by this extended fear avoidance model by Crumbus and colleagues. You probably know the traditional fear avoidance model, and maybe you have also seen this model. But basically what this model adds to the traditional fear avoidance model is that valued life goals, if you are able to pursue those and you are able to identify those and set goals in relation to those, then you'll see this approach behavior that's the way to recovery. However, if you get stuck in this pain problem and you try everything in or you spend all your time in your life to try to control something that can't be controlled and that can't be fixed, you try all kinds of treatments, then you waste your life, and then you move farther and farther away from your life goals. And this creates distress and frustrations and even more pain. So based on this model, we developed an intervention where we focused on 6 core elements. The first one was around psychoeducation about pain. You could call it pain science. It's many words are used for that today. But basically what we did was that we connected with the pain stories and tried to investigate how did the patients interpret their pain problem. And then you sort of modulated our, the newer pain theory on top of their explanations. And I'll give you some examples of what we did. And then we spent quite a lot of time identifying life values and translated those into value-based goals and very specific activities on what day, on what hour, how many times a week they should pursue this activity. And then we followed up on the week after and identified barriers for not doing it. And if they didn't do it, then we asked them why and what we could do to make it a success the next week. So in that way, it was a very behavioral intervention, but rooted deeply in life values. Then, of course, we worked traditionally with energy and activity management. We did a lot of exposure if they feared different kinds of movements, but only if they were an obstacle for doing this valued activity. So we didn't do traditional exposure, just if they were afraid bending you over, then we didn't necessarily expose them to do that if it wasn't an obstacle. But many of them said, well, I can't play with my grandchildren anymore because I can't lay down on the floor. Then the physio worked with them to being able to lay down on the floor, not fearing laying on the floor, playing with the kids. And then in the program, they also discussed with the patients exercise and movement in general, what made sense to them, so they didn't lay on the sofa every day. And then we did some relapse prevention strategies, talking with them about what are the signs that you are falling back to old habits. What can you do if that happens? Who can you say out aloud to that you have to stick to this program or whatever it was? And we applied a lot of techniques from CBT and acceptance commitment therapy, and also some techniques from CFT, and a lot of motivational interviewing. And actually motivational interviewing, if you want to know more about that, Roland Milnick's book called Motivational Interviewing, that's highly recommended because it gives some very clear and specific ways of discussing these behavioral changes with the patients and enhancing motivation, because you can't motivate patients, you can evoke motivation. And this is what this really is about. But what we did in this first trial was that we adapted all these techniques. It was applied first by a psychologist only in 10 sessions. And then later, that we have just finished this single case experimental design, we had physios delivered. But I'll show you the results from the psych that has delivered these 10 sessions of value-based CBT firstly. And remember, they didn't receive any exercise, guided exercises at all, and they didn't receive any manual treatment. This was only talk therapy and only motivational interviewing and having them to engage in value-based activities. And what we found here on one of the more hardcore outcome measures as the neck disability index, because this was 90 whiplash associated or whiplash patients that were randomized either to receive this treatment within 3 to 6 months after their injury or to a waitlist group. And then they waited for these 3 months and then they received the treatment as well, because we were interested in whether there were a treatment window, like this window of opportunity. And what you can see here is this is the waitlist group up here. They recovered a little during the first 3 months of wait, and the other ones, they recovered a lot. This is a huge effect size. And we see the same at the neck disability index. However, when they got the treatment, those that were waiting, this was then between 9 and 12 months after the injury, they also got an effect, but they never declined to the same levels as those that got the early treatment. And remember, the only thing that we did here was that we treated behavior. We had them to engage in activities that they loved, and we programmed it every week when they should do it. And we saw the same pattern on pain intensity. Then I'll show the result from this value-based living approach we applied with physios, mostly doing the treatment. And we applied this single case experimental design here. What we wanted to investigate in this design was whether this approach would increase value-based living and reducing pain and interference for these people. And then we wanted to investigate the temporal associations between a lot of outcomes, as you can see here. Because in the trial, we didn't know if it was the value-based living that decreased pain or whether it was just, positive expectations or attention or whatever. So in this kind of design, instead of just measuring something pre and post, then we measure all these things just by single items every single day. In the waitlist period, we randomize that, and then we have a treatment period. So instead of understanding a complex phenomena like a jump, it wouldn't make sense to look at that pre and post, right? So we assessed the whole trajectory of change. And in this trial here, we had a psychologist spending the first 3 sessions, 1 hour with the patients to help them discover what are my most important life values and how could I pursue these life values. And so they set some goals and some activities that could support these values. And then the physios took over for 7 sessions of 1 hour where they supported them to pursuing these life values. And if there were obstacles that hindered them to pursue these life values, then they worked with those. And coming to reflect about this study, then I think the physios could have done these exploration of life values equally good as the psychologist could. They were very skilled physios and they had 20 years of experience, but they were very good with meeting the patients and engaging with them and being empathic and, asking for how pain interferes with their lives. So in this is just one of the cases. I won't spend too much time because this is really the very typical whiplash patients that many of you probably know about. But this could be a typical patient that has a lot of, disturbances in her life because of pain. So some of the key messages that we worked with was that pain does not equal damage. You, of course, know that. And then we worked with this, that the pain predicts the world and it's actually also how perception of the world works. And then we showed them some of these visual, what's that called? Some of these visual illusions, and they could really easily understand that. We showed the brain scan, as I showed you before. And then we talked about pain more like a memory than solely some things coming from the body. And then we talked about the pain system can be turned up and down. And we actually only used these 4 printouts here. And we didn't show them these printouts, all the patients, but for those who made sense, we used them. And when we connected to their pain stories, we also had a patient that had a very biomechanical understanding of her pain, of her neck pain, but she were very eager to pursue the program and to pursue her life value. And it was very easy for the physios to translate those life values into goals and activities. But she had a very biomechanical understanding, but that was perfectly okay because we could change her behavior. So changing behavior is the driver of recovery. And she actually recovered quite nice, even though she didn't buy into all this pain neuroscience. Pain neuroscience is only important if it's important for the patients to engage in other behaviors. Remember that. So some examples of what we did, and I think it's a very simple and structured way to approach life values. We actually just used the Pain Disability Index, which is in this version that we used, it's 7 domains in your life. That could be family, work, and recreation, social activities. And then we asked them on a scale from 0 to 10, how disabled do you experience yourself within this domain? And then depending on where they put their cross, if it was above 5, then we interviewed them. Well, you put an 8 here. What's bothering you? What life roles are threatened here? And then they put all these activities and roles down here. And then they ask, well, if you're going to move from an 8 to like a 4, or what do you think is realistic after these 3 months of treatment? And then if they say, well, I want to move down to a 3, then the physio asked them, well, how would that look? What can you do if you're at a 3? And sometimes they came up with very unrealistic expectations. But then we asked them, well, you say it's important to play football again. What is so important about football? And then they talk about the social part of it and being with friends. And then we translate that's a value. We translated that into other activities and goals. So working with it like that, then we prioritize it. For her, Sophie, that I showed you before, what's most important for her was to be a good mother or experience herself as a good mother. And that was to pick Joe up from football, sit down and watch him play, letting him invite friends home. And the barriers was that she often prioritized the daily chores and had too much pain. And she was yelling and being angry and she did all these responsibilities herself. So by finding, other ways of doing that, so she has enough energy to be a good mother, that was her first priority. And then we actually translated that very simply into activity diaries. Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday. They get these 7 sheets with them home, and then we filled out the first one with them. Well, if you have to put 2 of these important life values into your life next week, and you have to translate that to 2 activities. We started with 2 activities, and then we progressed up to that every day they did something that was in line with their life values. And then we asked them, when are you going to play with Joe? Now that will be 2:00 when he's home from school. Okay, how are you doing? How will you do it? When will you do it? Who should it be with you? Should it be him alone? Very, very specific activities planned. And then they filled this out, and the week after they brought them to the therapist, to the physiotherapist, and then they discussed, well, why didn't it work? Oh, I was too tired and I couldn't play with him. I couldn't play soccer with him. So I watched him play football in the garden, and then I got a really bad conscience because now I'm here with headache and he's playing with himself. Then we asked, what could you have done instead? Oh, well, we could have, read a book, or we could have played a game, something else. And then they planned that the week after. Very, very, very simple, but rooted in life values. And this is an example of how we approach barriers and having a plan B. So what's practical? Are there any practical barriers, physical barriers, thoughts and emotions? And what did you do? What could you have done instead? So we really did this behavioral therapeutic approach to help them really achieve their life values. And we also taught them about this cognitive model that thoughts, behaviors, emotions, and bodily sensations, they all are linked together. And if you work with your thoughts, then it affects your behavior, and this affects emotions, and etc. And we also talked a lot about if you can change behavior and have this plan B, then your thoughts may not be so distressed, and then you may not be so sad, and you may not feel pain in the same way. So we worked around pain in this way. And what we found, this is one of the patients that I've just plotted here, was quite amazing. When we look at value-based living, how much they feel that they are doing activities in line with their life value, then in the waitlist period, we can see this goes up and down from a scale from 0 to 10. And then during the treatment, we see that she was more and more engaged in this value-based living. And in parallel, we saw that pain interferes less and less in her everyday life, and at the same time, pain intensity declined significantly as well. And what's nice about this method is that you can actually do statistic on single cases because we have enough data points instead of doing group statistics. So we're analyzing the results right now, but it seems that they work or they behave in similar ways in the other patients, that it's actually engaging these life values that changes pain, not the other way around. So this is quite interesting that we maybe don't need to treat pain, or we don't even need to do some exercise and manual treatment if we can have patients to engage in what's important to them. So to work with these values and goals is really the core. So if we understand what people value, we also have the key to what motivates them and what motivates them to change behavior. So it's really important to explore these life values because it is this strong source of motivation. And if we can help them to perceive this discrepancy between the behavior that they are having right now and what they want, then you can motivate them to pursue these life values. I just want to spend 2 minutes on showing you some of the examples or some of the techniques that you can utilize, because it takes a whole training course to apply this, but we actually only trained our physiotherapists and supervised them for after every session for in total like 20 hours each, or they did it in groups. So it takes like 20 hours of training to master these techniques if you are a skilled clinician. So you can easily explore these values and goals by just asking simple questions like this. And I'll share the slides with you. So this could be, tell me about what you care most about in life. What matters to you? How do you hope your life will be different a few years from now? And what do you try to live up to? And etc. You can also use some more structured approaches. You can find these cards in different languages on this homepage. I don't get paid for advertising for it, but it's a nice structured ways, like a Q sort method, where there are some statements on the cards that they need to sort depending on how important that they think this statement is. And then this is a structured way of talking about life values. And you can also find these cards for free. That's actually modulated around Rogers humanistic therapy. And they are very clear and easily to understand, these cards. You can just download them and experiment with them. Sometimes it's nice to have a structured way of engaging in these conversations with our patients if we are not trained in these soft skills. And then finally, I'll just recommend the William Miller and Rolnick's book on motivational interviewing. It also has some very nice examples of how you can work with expressing empathy and support self-efficacy, and what they call roll with resistance instead of, try to argue with your patient. There are some very clever ways of interviewing and asking questions that enhance motivation instead of you get caught up in this resistant stance with the patients. And this is really about developing a discrepancy in helping the patients to realize the behavior that I have right now. That's not what I really want, but you don't need to tell them, the patient. You need to ask them about it. So I highly recommend that. So I think I've spent my time now.